Hello everyone, good evening. I'll be talking about a term called Pupillorhexsis, which is a novel technique for management of pupillary membrane, which causes non-dilating pupil in especially long-term uveitic cataracts. So the cataract that is caused by chronic inflammation of recurrent uveitis, inflammation leading to the formation of pupillary membranes. Now they cause a very challenging surgery because it causes the restriction of the dilatation of the pupil, hindering a proper visualization and access during the cataract surgery. So these non-dilating pupil, the synecdoche that is caused between the iris and the capsule, it causes the failure to dilate. The conventional techniques often comes handy using iris hooks or rings or pupillary dilators, but they have some limitations and complications associated with these methods. So what is pupillorhexis? It's a technique that involves creating a controlled tear of the and removal of the pupillary membrane. It causes the restoration of the pupillary dilatation by eliminating the membrane's mechanical restriction. So I'll be presenting a case. This is a case 1. I'll just move forward. So this is a uveitic cataract, and you can see the synecdoche all around 360 degree, and there is a membrane. So the key is creating a window between the membrane and the anterior capsule. So you can see I'm making a window between the iris and the anterior capsule with the help of a repositor. And once this window is created, you can separate the diaphragm. Now you can see the pupil is now nicely dilating after the constriction is broken and the membrane is removed. After the removal, you can see a 360 degree membrane. It comes out intact in one piece, which leads to a free pupil that can easily dilate, and we can carry out our cataract surgery unhindered. The last piece of the membrane is also removed, and here is the intact membrane that you can see. Very good. So now the mechanical restriction is broken, and the phacosurgery can be carried out nicely. The rest of the procedure was as usual. There's a second case 2. You can see I have taken out a piece of the surgery. So the pupillary membrane is being removed. It comes out very nicely once you have a good window and a good hold at the pupillary margin. And the entire membrane can be peeled off like a rhexis is made on the anterior capsule. These kind of pupils, they usually dilate and they respond very well to pupillary dilatation, to adrenalines. And here the intact membrane is removed from the iris. The membrane usually comes off in toto, but sometimes it causes some breakage, and you can get a complete rhexis done. Okay, this is the case 3. You can see the constricted pupil. The dye is coming out from, because we inject the dye behind the iris. So during the process, some dye keeps coming up in the view. But you can see the pupil is being released slowly after the membrane is released from the pupillary margins. And these pupils, they usually react very well and they respond to the intraocular dilatation. So the key is, if we use iris hooks or any dilators while the membrane or the pupillary synapse are present, it will cause the breakage of the pupillary margins, and post-surgery you'll have a very rigid, a very ragged, very disturbed pupil. And if you use a technique like this and you remove the membrane entirely from the pupillary margins, post-operatively you'll have a very nice reacting pupil which is usually free from any of these synapse or membranes. Now, this is the last case. This case was a young male. This was a young male who had undergone a VR surgery. He had undergone VR surgery for RD surgery, then he went on for SOR, but there was some oil remaining in the anterior chamber.
The cursor is not showing.
So this case didn't have a complete membrane, but you can see partially, you can see there is a good synapse that is present all over, and it had some pupillary membrane fragments along the pupillary margins. So this was causing the undilated pupil, and once you remove these fragments from the pupillary margins, the pupil gives way and it easily dilates. So once I'm breaking the synapses and we're removing this pupillary membrane along the margins of the pupil, so they come off very nicely with the help of a rhexis forceps, a microforceps. And once you remove these membranes entirely from the pupillary margin, you have a very good dilating pupil, and your entire surgery does not require any assistance of pupillary dilatation or iris hooks or any dilators. Am I okay? Okay. Yeah. I've just finished. So this the keynote is identifying the pupillary membrane, distinguishing it from the anterior capsule and the synapse, performing a rhexis with a micro instrument, and achieving a free pupil post-rhexis. So this gives you a very easy surgery. We does not require any iris hooks, it gives you a better pupillary dilatation intraoperatively and good visualization of the surgery. Thank you.
Any chances of iridodialysis while you're pulling